Hello everyone. Hello everyone. I'm Anas Al Ubaidi, and the title or the topic for this lecture is Endocrine Disease Documentation, Type 2 Diabetes, and Thyroid Disorders. And it is within Chapter 31, which is about review of endocrinology and rheumatology scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Endocrine diseases, particularly type 2 diabetes mellitus (T2) DM for short, and thyroid disorders, are among the most prevalent chronic conditions encountered in clinical practice today. Accurate and thorough documentation of these conditions is essential for effective patient management, as it plays a critical role in tracking disease progression, guiding treatment decisions, and identifying potential complications. For medical scribes, mastering the documentation of these endocrine disorders ensures that providers have the detailed information they need to deliver high-quality care. Type 2 diabetes is a chronic metabolic disorder characterized by insulin resistance and impaired glucose metabolism. It is a leading cause of complications such as cardiovascular disease, nephropathy, neuropathy, and retinopathy. The management of T2 type 2 diabetes, T2-DM, requires a multidisciplinary approach involving glycemic control, lifestyle modifications, and monitoring for complications. Scribes play a key role in documenting lab results such as HbA1c and fasting glucose, describing symptoms like polyuria or fatigue, and recording treatment plans, including medication regimens and patient education. Thyroid disorders, including hypothyroidism and hyperthyroidism, affect millions of patients and can significantly impact metabolism, energy levels, and overall health. Accurate documentation in cases of thyroid dysfunction is crucial for diagnosis, monitoring treatment response, and identifying complications. For example, in hypothyroidism, proper recording of symptoms such as fatigue or weight gain, alongside lab results like TSH and FT4 levels, is critical. Similarly, for hyperthyroidism, documenting signs such as palpitations, unexplained weight loss, and ophthalmopathy ensures comprehensive patient records. Key points. Type 2 diabetes documentation, complete symptom documentation. Scribes must accurately document patient-reported symptoms and how they relate to the progression or management of T2DM, type 2 diabetes mellitus. Key symptoms to capture include classic symptoms of hyperglycemia, document excessive thirst, polydipsia, frequent urination, polyuria, and the unintentional weight loss. For instance, note details such as patient reports urinating every 2 to 3 hours, including waking up twice nightly. Fatigue and lethargy. Chronic hyperglycemia often leads to low energy. Highlight any reports of fatigue interfering with daily activities. Neuropathy symptoms, tingling, numbing, pain in extremities should be documented, including the onset and severity of discomfort. Clear documentation of these details helps identify uncontrolled diabetes or undiagnosed cases. And here's a diagram summarizing the symptoms of type 2 diabetes mellitus. Glycemic markers and testing results. Advanced scribes must understand common lab tests for diabetes and how to rely these results in documentation. HbA1c results provide the percentage value of its interpretation. Note phrases like patient's HbA1c has elevated from 7% to 8.6% over 3 months, indicating worsening glycemic control. Fasting plasma glucose, FPG for short, record consistent numeric results. For example, FPG noted at 140 mg per dl on 2 occasions, meeting diagnostic criteria for diabetes. Blood sugar trends highlight trends from glucometer readings when provided, identifying patterns or spikes. And here is a diagram showing the diabetes lab tests. Chronic complications and screening. Diabetes documentation involves monitoring and tracking complications. Key points include diabetic retinopathy, not findings from ophthalmology visits, such as evidence of microaneurysm formation. Nephropathy include abnormal urine protein tests, microalbuminuria. Neuropathy document clinical examinations like filament testing results. Always ensure that recommendations for follow-up, for example, annual dilated eye exams, are noted appropriately. And here's a diagram summarizing the diabetes complications, monitoring, and documentation. Treatment documentation. Scribes need to provide detailed records of prescribed treatments, medication regimens, lifestyle interventions. Red flags in diabetes cases, and this is critical, as key red flags indicate urgent issues requiring provider attention. We have severe hyperglycemia or hypoglycemia episodes. For example, blood sugar below 50 mg per dl with confusion, diabetic foot ulcers or gangrene, signs of diabetic ketoacidosis, DKA for short, abdominal pain, fruity smelling, breath, all requiring immediate escalation in care. Thyroid disorders documentation, complete symptom profiles, accurate documentation of symptoms linked to thyroid dysfunction ensures effective diagnosis. Hypothyroidism, capture fatigue, cold intolerance, weight gain, dry skin, and bradycardia, low pulse rate. Patient reports feeling cold even in warm temperatures with unintentional weight gain, for instance, of 10 pounds over 2 months. Hyperthyroidism notes symptoms like palpitations, heat intolerance, tremors, and weight loss. Record findings such as patient with unexplained weight loss of, for instance, 15 pounds despite normal appetite. Essential thyroid function tests. Understanding and documenting lab tests is crucial. TSH, thyroid stimulating hormone, a high TSH indicates hypothyroidism, while suppressed TSH suggests hyperthyroidism. Includes specifics such as TSH elevated to 6.5 MIU per liter. Free T4 and free T3. Record actual hormone levels as free T4 decreased to 0.7 ng per dl, supporting a hypothyroid diagnosis. Integrate these lab values to create a clear diagnostic picture. Documentation of treatment plans. Accurate recording of interventions for thyroid disorders includes hypothyroidism, document thyroid hormone replacement details like started levothyroxine 24 mcg daily with weekly follow-up TSH monitoring. Hyperthyroidism, record antithyroid medications or more advanced treatment plans like radioactive iodine therapy. Include any changes in medication based on lab results or side effects. Monitoring and follow-up. Regular follow-up is critical for thyroid conditions. Scribes should document changes compared to prior labs. Adjustment of medications and patient-reported improvements or worsening symptoms. Then we have complications and clinical red flags, and this is critical and essential as well, and important. As key complications to watch for, hypothyroidism untreated leads to myxedema, coma. As a complication, emphasizes symptoms such as altered mental state or hypothermia. Hyperthyroidism, if associated with severe tachycardia, high pulse rate, severe fever or confusion, suspect thyroid storm, a life-threatening emergency. Clear and precise documentation in these cases guides rapid escalation. Next, we have the summary tables. Here we have table on common symptoms of endocrine disorders and their characteristics. Here we have table on diagnostic tests for endocrine disorders. Here we have a table on key diabetes and thyroid treatment plans, table on red flags on diabetes and thyroid documentation, table on follow-up and monitoring recommendations. Next, we will revise what we have covered through this lecture via some MCQs or multiple choice questions. Question 1. Which lab result indicates type 2 diabetes according to diagnostic criteria? A. HbA1c of 5.4%, fasting plasma glucose of 128 mg per dl, random glucose of 170 mg per dl, TSH level of 4.5 MIU per liter. So definitely it's the fasting plasma glucose of 128 mg per dl, as this is too high. So B is the answer. A fasting plasma glucose FPG level of 126 mg per dl or higher is a diagnostic criterion for diabetes. HbA1c of less than or equal 5.6% is normal. Random glucose needs to be more than or equal 200 mg per dl for diagnosis. And TSH is used for thyroid disorders, not diabetes. Question 2. What is the primary symptom of hypothyroidism that needs comprehensive documentation? A. Heat intolerance. B. Weight gain and fatigue. C. Prolonged diarrhea. Or D. Palpitations. So ACD with hyperthyroidism, but with hypothyroidism is B, as weight gain and fatigue. So hypothyroidism often causes fatigue and weight gain due to slowdown of metabolic functions. Heat intolerance and palpitations more associated with hyperthyroidism, hyperthyroidism, and diarrhea actually is unrelated to hypothyroidism. Could be with hyper, but more likely heat intolerance and palpitations more than diarrhea with hyperthyroidism, but doesn't mean there isn't diarrhea with hyperthyroidism. There could be diarrhea with hyperthyroidism. However, the only hypothyroidism symptom here within the four symptoms or four options is B, weight gain and fatigue. Question 3. What red flag in diabetes documentation indicates the possibility of diabetic ketoacidosis, DKA? Is it A, blood sugar level of 90 mg per dl, B, cool clammy skin, C, fruity smelling breath and abdominal pain, or D, TSH level of 0.1 MIU per liter? So definitely it's C, fruity smelling breath and abdominal pain. As fruity breath and abdominal pain and other signs such as rapid breathing are classic symptoms of DKA. As DKA here is a life-threatening complication of diabetes requiring urgent care. Cool, clammy skin points to hypoglycemia, not DKA. Question 4. Which test result supports a diagnosis of hyperthyroidism? This time not hypo, but hyperthyroidism. Is it A, elevated TSH and normal free T3, T4? B, depressed TSH and elevated free T4? C, normal TSH with elevated HbA1c? Or D, elevated fasting glucose and TSH? So, as we agreed and we went through the session through the slides, with hyperthyroidism, high thyroid levels, TSH will be low and T4 and or T3 will be high. And the only applicable is B, depressed TSH and elevated free T4. As hyperthyroidism typically presents with low TSH and high free T4 or T3 due to excessive thyroid hormone production. Elevated glucose relates to diabetes, not thyroid issues. Question 5. Why is it critical to document the initiation of levothyroxine treatment in hypothyroidism? So A, to monitor for weight loss therapy. B, to track improvements in free T4 and symptom resolution. C, to determine the patient's blood pressure response. Or D, to identify risk of developing hyperthyroidism. So it is B, as to track improvements. As levothyroxine replaces deficient thyroid hormones, so monitoring free T4 levels and symptoms like fatigue ensures the treatment is effective, while incorrect dosing could lead to hyperthyroidism. This is not the primary reason for documentation. And here we come to the end of this lecture. Thank you very much and goodbye.